So thank you all for coming and for the opportunity to present today on the role of echo in rheumatic heart disease. Yeah, so okay. I'm going to go through a couple of objectives. The first one is to review the morphologic and functional cardiac changes associated with rheumatic heart disease, discuss the role of echo in the evaluation and management of rheumatic heart disease, and then finally briefly discuss the implications of rheumatic mitral stenosis in pregnancy. Which is interestingly related to the primary case that I based this off of. So this is a 43-year-old female who presented as a G2P1, gestational age 23 plus 5 weeks, to a cardiology clinic. Her past medical history included prior pregnancy in 2009, which was a spontaneous vaginal delivery at term, and gestational diabetes at the same time. She also had thalassemia, trait, hypertension, ocular HSV, and possible asthma. Her whole social history includes that she lives with her partner and one healthy daughter, and she was a non-smoker. She didn't have any significant alcohol use. She came in with atypical chest pain and also shortness of breath on very minimal exertion, as well as orthopnea to about 40 degrees. She didn't have any frank paroxysmal nocturnal dyspnea, but woke up with a dry cough. On physical examination, her heart rate was described as being 85 to 90 beats per minute. Her blood pressure was 130 over 75, and she had a loud first heart sound, as well as normal second heart sound, as well as a diastolic murmur with an opening snap. She had clear chest, she had no peripheral edema, and her JVP was not elevated at that time. So the first investigation, given that this is an echo talk, is we'll talk about her echo, and I hope you guys can see this slide. So I'm just going to play the video here. Just because of time, I thought I would go through the clip here. So this is our sternal long axis of this patient. Basically, what's impressive, I think, for all of us looking at this is the mitral valve. You can see that there's a brightness in the leaflet of the anterior mitral valve leaflet. It looks calcified. There's maybe some thickening of the valves, and there's certainly restricted motion of the mitral valve. And I'll go through the motion of the valve further on in detail, but both leaflets appear to be restricted. So far, I think our assessment of the LV function looks like it's, I know it plays very choppy, but it's pretty, and the RVOT size, the aorta is not impressive. There is, however, very impressive left atrial enlargement. And so here we have a zoomed up view of the mitral valve in the peristernal long axis. And with color compare, we can see that there is a significant diastolic flow acceleration through the valve. There's also a small amount, or what we see so far, of mitral regurgitation here. And looking here, this is the peristernal short axis on the left side. And we can see there's, again, thickening of the mitral valve leaflets. It looks like there's restricted mobility. And there's also some fusion of these sides of the medial and the lateral commissures. And this is her apical four-chamber view. And this, we can see that, again, the mobility of the leaflets is very similar to what's described as very restricted. And there's a large left atrium. The RV actually, if it plays okay, if you guys could see, has normal RV function and size, and the right atria looks normal. And if we go through the color here, similarly, there's a significant systolic gradient, and with a bit of a jet of systolic mitral regurgitation. And we put the CW Doppler through, you can see that the max gradient is about 50 with a mean gradient of 27, and at a heart rate of about 85 beats per minute. So this is unsurprising probably for a lot of people, that this represents the features of rheumatic heart disease. I thought I discussed, first of all, some of the epidemiology, because despite the fact that it is declining in terms of overall trends. Acute rheumatic fever has been eradicated in a large part of the world. The global impact is still very significant, especially when we consider low and middle income countries where rheumatic fever remains endemic. And the prevalence ranges very widely. In 2015, it found this interesting that in endemic regions, there's more than 33 million cases are estimated, but in non-endemic regions, this is about 220,000. There's still a significant morbidity, mortality. There's about 300,000 deaths annually, and more than 10 million disability-adjusted life years lost when we look at the global burden of disease. And a lot of this is related to years of life lost, which suggests that premature mortality is a major driver here. And the areas of the world where this particularly high prevalence is Oceania, South Asia, and Sub-Saharan Africa. This global map sort of points out where the disability-adjusted life years is the highest, and you can see it maps out to the same areas where there is significant endemic acute rheumatic fever. So briefly just on acute rheumatic fever, this is an autoimmune reaction after a hemolytic strep infection. And the reason that this is particularly causes a significant disease is that it works through molecular mimicry, such that the antigens on this strep have similar features to host antigens, such as in the skin, in the brain, and in the heart. This is primed by multiple repeated infections and in a susceptible host with certain environmental factors that are susceptible, and in some ways some genetic factors. This leads to a first episode of acute fever. And over time, how we get to chronic rheumatic heart diseases and through repeated insults, basically, to the antigens and to the organs, such as the valves, with repeated episodes of recurrent acute rheumatic fever and ongoing inflammation. So the interesting thing is that acute rheumatic fever can be clinical or subclinical, and for only about 30 to 50% of people with rheumatic heart disease actually can recall an episode of acute rheumatic fever. They're most common in patients who are younger, in age 4 to 9, and the cardiac manifestations include pericarditis, valvulitis, and even myocardial dysfunction. And I'll go into the details, but the 2015 revised Jones criteria are diagnostic criteria for acute rheumatic fever. The valvular in acute rheumatic fever is different than in chronic rheumatic heart disease, which I'll focus more on, but there tends to be more left-sided valve that's regurgitant. It is related to mitral regurgitation, and this occurs as a result of annular dilatation of the mitral valve. There can be chordal elongation, and there's excessive leaflet tip motion as a result of this cord elongating. And very rarely there can be chordal rupture. Aortic regurgitation can also occur, but in isolation, this is pretty rare, and tricuspid and pulmonic valve disease are quite rare. Stenotic lesions tend to be less common in these early stages and more common as the progresses with more insults of recurrent acute rheumatic fever. So this is these images from a patient with actually acute rheumatic fever and valvulitis related to that. This is one I found online, but it demonstrates that there's already some changes to the mitral valve. You can see some leaflet thickening of the anterior mitral valve, but the posterior mitral valve leaflet, there's actually a ruptured cord, and there's a flail component that's going back to left atrium. I hope we can see that. And then if we go put the color on, there's actually significant mitral regurgitation. So the natural history is transition from acute rheumatic fever to chronic rheumatic heart disease is over the course of years. It's a chronic progressive disease, and it happens at different time points for different regions. In endemic regions, it happens faster than in non-endemic regions, which is where we tend to see patients present in more middle age. Interestingly, in Brazil, which would probably consider more of an emerging economy, 72% of children with acute rheumatic fever was found to progress to chronic valvular disease, and 16% had severe aortic or mitral disease. I thought it was pretty high, but this may be related in some parts of the region. And then progression to rheumatic heart disease tends to be highest in the first year. And this is how, over time, this occurs. There, if you can see my mouse, the initial, with the figure on the right side, the initial bottom side of the pyramid is borderline echocardiographic findings that are suggestive in still asymptomatic patients, and then there's subclinical and clinical disease, but either they may be a murmur present or not, but patients remain asymptomatic. Once you reach symptomatic rheumatic heart disease, then you can have significant cardiac failure with various sequelae and ultimately needing surgery or potentially passing away from this disease. So this is a spectrum from asymptomatic to symptomatic. So what are some of the symptoms? People tend to present with exertional dyspnea, fatigue, functional limitation, palpitations, and heart failure. And as I mentioned, they tend to present younger in endemic regions, in the teens to 30s, and in non-endemic regions tend to be in the 50s to 70s. And because of the hemodynamic pressures caused by pregnancy, this can often be a diagnosis that's actually made during pregnancy. And then after a certain episode of an acute complication, such as an acute heart failure episode, an atrial arrhythmia, an embolic event, or potentially having infective endocarditis. So how are the valves involved, the valvular involvement in rheumatic heart disease, this chronic form that develops over the course of years? They are predominantly still affect the left-sided valves. There can be isolated mitral regurgitation, isolated mitral stenosis, or a mix of regurgitant or stenotic mitral lesions. And regurgitation tends to occur earlier in young people, and once we have increasing age, stenotic and mixed lesions tend to predominate. The aortic valve can also be associated with stenosis or regurgitation, and they are associated with mitral lesions. 1/3 of patients with MS will have aortic involvement. And the tricuspid valve, similarly to in acute rheumatic fever, is rare, and in autopsy studies, they think up to 99% of patients with tricuspid disease also had mitral involvement or left-sided involvement, and pulmonic valve involvement is very rare. Looking, this is a global registry of about 2,000 patients with rheumatic mitral valve disease in countries that are in sort of the low-middle income group, and you can see that the early years, this light blue bar represents pure mitral regurgitation, and as you go into middle years, this green bar represents more mixed mitral and aortic valve disease, which is helps us inform what the type of patients that we would see. So I just wanted to go into a little more detail about the morphologic changes, which are these almost classic pathognomonic changes. And as we all know, that rheumatic heart disease is the most common cause of mitral stenosis. And so I'm going to talk first about the mitral valve and its apparatus. There is, because of the inflammation, ongoing long-term scarring, there can be a shortening of the chordae with thickening and fusion. And this can start to affect the leaflets, and they tend to affect first the leaflet tips. And as a result of that, it can have some nodularity or beating of the leaflets. There has to be one of the main features, actually, commissural fusion, so fusion of the medial and left commissures, and this happens from the outside inwards. Because rheumatic valve disease tends to affect these leaflet tips, this is one of the differentiating factors between degenerative mitral stenosis, which tends to be involve annular calcification that then spreads into the leaflet base, and so this is one of the ways that can be differentiated from degenerative calcific mitral stenosis. The other thing is that if chordal thickening and fusion happens alone without significant commissural fusion, this can have a predominant sort of mitral regurgitation appearing rather than a stenotic lesion. There can be restricted leaflet motion, and this is the classic diastolic dome anterior leaflet, and it's related to a combination of all of those things where there's leaflet tip thickening, commissural fusion, and this shortening of the chordae. And this is the classic kind of hockey stick appearance. And you can have a immobile posterior leaflet that either is restricted and does not move, or it can be moving towards the anterior leaflet, which is opposite its usual motion. In young patients, because there can actually be excessive leaflet tip motion during systole such that it moves towards the left atrium and without an obvious prolapse feature, and this is one of the reasons that mitral regurgitation will predominate first. And this type of excessive leaflet motion typically not seen in patients that are more than 35 years old. So this is sort of just a diagram, or sorry, a visual look at what I was talking about in the different leaflet motions in systole and diastole. The panels on the left side are, on both of these, are normal hearts, and then in the middle is rheumatic heart disease. And this is where you can see the leaflet tip motion being a bit excessive in systole, but not actually meeting, which is panel C, the criteria for mitral valve prolapse. And you can see how this looks different in comparison. In diastole, there's restricted motion, as I described, of the anterior and the mitral valve leaflet, and we'll see some of that further. So this is an M mode through the mitral valve, and this is one of the sort of classic teaching in M mode. And you can see where I'm highlighting with a mouse, this is the anterior mitral valve leaflet, this is the posterior mitral valve leaflet. It appears to be thickened. This is during diastole. And we can see that there's the slope between the E wave, which is here in the start of my cursor, and to the F wave, which is the onset of diastasis, is a decreased slope. And there can be either reduced or an absent A wave, such as related to atrial fibrillation. The posterior leaflet motion either be restricted or can be parallel and towards the enteromitral valve leaflet. These are some further still images, but this is in peristernal long axis. This is the classic doming. And this is peristernal short axis in the middle in B here, where you see thickening of the valve leaflets and also commissural fusion. And this fish mouth shape that happened, that starts to form classically as well. And here in C, you can see these chordae that appears to be very calcified, fused, and shortened. This typically you'd have to go in sort of an off-axis image to get. So how about the aortic valve? So in the aortic valve, there's very similar changes with irregular or focal thickening of the leaflets. The free edges tends to be thickened and retract and roll, and there can be committal fusion as well. The restricted cusp motion is related to a combination of thickening and commissural fusion, and that thickening in and of itself can cause this coaptation that will lead to irregular. And sometimes what I've read is that surgical just repair with taking away that thin area can improve the coaptation and aortic regurgitation. Because of the way that the leaflets retract and leaves this central coaptation gap, and it usually is triangular in shape. And sometimes there can also be excessive mobility or prolapse of the cusps to below the annulus. Now, the severity of aortic stenosis, just to know, could be underestimated in the setting of significant mitral stenosis as a result of the decreased stroke volume because of decreased left ventricular filling in the setting that severe mitral stenosis. And with aortic valve involvement, there could also be involvement of the proximal aorta. So the tricuspid valve involvement is quite similar to the mitral valve. There's leaflet thickening and diastolic doming. There's chordal thickening and fusion and commissural fusion, although valvular calcification can be quite rare. So this first image, still image here, is an RV inflow view. And you can see this is the posterior tricuspid valve leaflet here, which appears to be thickened, and there's doming. And the same thing is shown in this apical four-chamber view, where there's doming of the leaflets with thickening. And both of these atria are very large. And when we put GER on, there's significant diastolic flow acceleration through this thickened valve. Interestingly, there's also some systolic dysfunction that can occur in about 25% of patients based on some early studies, and they do have a propensity for the posterior wall. The exact reason for this is unknown, and looking at the pathology slides, there's actually no evidence of myocardial damage. And so the thought is that this may all be related to reduced LV filling as a result of, and the relationship as from poor LV filling leading to decreased preloading, to decreased systolic function. There can be tethering of the cords preventing the LV from expanding during the diastolic phase. But interestingly, there's also this leftward motion that results from differential filling of the LV and the RV the LV tends to feel less compared to the RV, and there can be a persistent leftward motion of the interventricular septum during diastole. So in 2012, the World Heart Federation actually provided guidelines not for diagnosis of rheumatic heart disease, for example, in a lab like St. Mike's in Canada, but to look for asymptomatic subclinical rheumatic heart disease in predominantly endemic regions to have a better consensus definition for this. Basically, they looked at various features of mitral valve and aortic valve that I've discussed and determined whether or group them into definite rheumatic heart disease, borderline rheumatic heart disease, or and grouped by people who are less than 20 years and over 20 years. Just epidemiology can be differences in some of the what's considered pathologic and not pathologic in these patients. And you can see the criteria for pathologic regurgitation that they talk about are not a traditional criteria that we use to look at the severity of regurgitation, but this is really to look at in patients who are, for example, 19 or 20 years old. What are the parameters that you would look for to determine whether this mitral regurgitation is trivial and non-pathologic, or whether it's pathologic and could present rheumatic heart disease? And they specify this is not for patients who have a known history of acute rheumatic fever. If you have a history of acute rheumatic fever, basically any structural or functional abnormality of the heart should be considered related to rheumatic heart disease first, until proven otherwise. And this is obviously in a pretest probability, you must have a pretty high pretest probability of rheumatic heart disease, and other congenital causes or acquired causes should be ruled out. So I think this is something interesting to highlight, is that the idea of these screening guidelines created for echo to be used as a potential tool to detect these latent rheumatic heart disease. And the goal is to initiate secondary antibiotic prophylaxis. As we know, this is effective to reduce the recurrence of acute rheumatic fever in someone who's had an episode in the past, and potentially offer patients with earlier therapeutic intervention, either with surgery or catheter interventions. Ideally, this would be done when, when we can, to pick them up in the mild to moderate severity stage, and in school-age children who would most likely to benefit because we can initiate antibiotic prophylaxis earlier and they're more likely to have mild disease, and in pregnant women who have a very high risk of complication if they live with, continue their pregnancy with rheumatic mitral disease or rheumatic valvular disease. And it has helped us understand some of the differences in prevalence, in these regions. So in endemic regions, there's about 7 times higher prevalence of subclinical disease that's not seen than in clinical manifest disease. So there's definitely a high area of need, and it's advanced advocacy in these areas, in these regions, such that they've initiated registries and secured a supply of antibiotics based on what we know from echo screen. And it's going to be an area of ongoing research first to establish, is there really benefit of antibiotic prophylaxis in these patients that are found to have borderline or mild definite rheumatic heart disease, and whether this is really a cost-effective goal going forward for a public health screening strategy. This was an interesting study of using handheld echo in Uganda to look at, compared to standard portable echo in 125 children. This is a prospective observational study to look at whether this is something that can be a cost-effective, portable way of searching for latent rheumatic heart disease or screening for rheumatic heart disease. So the prevalence data, they basically, one person completed paired echoes, either by a handheld echo, like a V-scanner, or a standard portable echo with a vivid eye. The prevalence in this study was 16 was found to have borderline rheumatic heart disease, and 20 had definite rheumatic heart disease by their echo machine, which was considered the gold standard. And the handheld echo actually performed pretty well with for any positive rheumatic heart disease, a sensitivity of around 90s and a specificity of also around 93%. For definite rheumatic heart disease, there's about 100% sensitivity and 96% specificity, and this is lower in where there's borderline cases. There's some overcalling of morphologic changes of the valve disease, but the other limitation is that there's no CW, there's only color Doppler and 2D echo, and so we don't have the ability to assess sort of jet velocity, for example. But you can see these images are actually quite comparable. If you look at the left side, these are the ones acquired from the standard echo with color Doppler, and the right side are the ones acquired with the handheld echo. And just to show that they can develop some fairly comparable images. And so this is going to be something of interest, I think, going forward, in another use of a portable echo or POCUS. So I want to talk a bit about the hemodynamics of mitral stenosis and how this will then inform our way of assessing its severity on echo. So when you have mitral valve orifice narrowing, a normal mitral valve area is about 5 to 6 centimeters squared, and when it gets to about less than 2 centimeters squared, there can be significant increase in hemodynamic changes and symptoms. So when there's narrowing, there has to be a pressure gradient that drives the blood from the LA to the LV. And you can see in these hemodynamic tracings, this one that I'm pointing at, the long one here on A, is the LV, and the one here with the V wave is panel L, is the LA. And you can see that in diastole, there is a significant gradient of the LA and LV pressure that persists throughout diastole. And it's similarly seen in this patient with mitral stenosis down here with wedge pressure tracing and a simultaneous LV pressure tracing. The gradient tends to be highest in the initial phase of diastole and then decreases over the course of diastole. And the thing to notice is that they never reach diastasis, where the LV and the LA pressures are close to each other. And so this can result in significant increase in LA pressure and dilatation of the left atrium. And subsequently, this pressure gets transmitted to the pulmonary circulation, causing pulmonary hypertension. So we talk commonly about the transmitral gradient, which is obtained through this transmitral flow curve, as we see abuse in mitral valve. And it can be dependent on many factors like heart rate, transmitral flow, and diastolic filling. Basically, the greater flow that you have to get through this small orifice, and the less time you have, the higher that gradient will be. This is a adapted chart from the 2014 circulation AHA valvular heart disease guidelines, looking at their cutoff ranges for mitral valve area for mild, moderate, severe, and very severe, and also for mean gradient and pulmonary artery pressure. Mitral valve area of less than or equal to 1.5 is severe, and less than or equal to 1 is very severe. And while mean gradient and pulmonary pressure are important, and we look at them, we would not necessarily use them as the main markers to say which one's severe or very severe. The mitral valve area tends to be the main factor, because the gradient and the pulmonary artery pressure can be affected by many other factors, as I mentioned. And progression of mitral stenosis over time is about 0.09 centimeters squared per year. So this is a more up-to-date 2020 valve guidelines looking at how progression of mitral stenosis is staged from A to D. And just for time, I'm going to go on, but very similar in terms of cutoff with 1.5 centimeters. So determining the mitral valve area, because it's so important, I'm just going to go through a little bit. So ideally, the gold standard is to do this by direct planimetry, either by 2D or 3D echo. And it's important that it be performed at the least at mid-diastole. And it's important and to do this in parasternal short axis, and important to actually scan through the entire mitral valve, because it's doming in diastole and it can have this funnel shape. You want to find it just at the leaflet tips to take the mitral valve area. The other way of doing this is through mitral pressure half time, and this is basically related to the rate at which the falling LA pressure and the rising LV pressure takes it, the rate at which these pressures equilibrate, and the time it takes for the maximum diastolic mitral gradient to get to 1/2 is the pressure half time. And the longer the longer this takes, the more severe the mitral stenosis. And prior hemodynamic studies have shown that at a mitral valve area of about 1 centimeter squared, our pressure half time is 220 milliseconds. And so this is where we derive this formula, the Hadley formula of the MVA equals 220 divided by pressure half time. Other less commonly used methods would be the continuity equation and the PISA method. So just to show you graphically, this would be the CW Doppler that's derived with time in the x-axis and velocity in the y-axis. And you can see the Vmax, this is the peak Vmax, and then the pressure half time is basically a mathematical calculation where Vmax reaches, where the velocity reaches Vmax divided by square root of 2. Now, there can be certain, looking at the figure on the right side, where there would be bimodal CW Dopplers, where there's initially a very steep decrease in the Vmax, followed by a less steep decrease. And this is related to changes of the LA operational compliance. So not that the compliance has changed itself, but where they are on its LA pressure volume curve. And initially, this phase where the LA is stretched and a higher volume, there's a decreased pressure operational compliance. And this actually relates to a faster or shortened pressure half time, and it's this faster downslope. And where the operational compliance increases over time, as the left atrium empties, the operational compliance increases and the pressure half time actually lengthens. There is therefore a direct relationship between the compliance and the pressure half time. And so the ideal area to take the pressure half time is actually from this mid slope and not the initial steep slope. And there's some caveats to this pressure half time method, because the Hatley formula I talk about considers only the relationship between pressure half time and the mitral valve area, but not the other factors, which are compliance of the LA and the LV. And so pressure half time can be shortened where there's impairment of the LV compliance. There's the LV diastolic pressure rises very quickly, and so that gradient, if we go back and think about the hemodynamic tracings, that gradient will very quickly diminish. And that can happen in LV diastolic dysfunction, such as with HFpEF, or with significant aortic regurgitation. If there's common atrial septal defect, there can be basically runoff of flow into the atrial septum, into this defect, and not through the mitral valve, and that therefore this shortens pressure half time. Where there's change in LA compliance, as I mentioned earlier, with impaired LA compliance, the pressure half time can shorten. And this may be a reason in mitral regurgitation. We can sometimes have an inaccurate estimation of mitral valve area by pressure half time. However, from my reading, this seems to be somewhat debated, and this relates to the same concept that if there's significant LA volume overload, this changes the LA's operational compliance and can shorten pressure half time. But if we look at the slope in mid to late diastole in mitral regurgitation, it's unaffected, and so it may be accurate. And then the last thing is immediately post-balloon valvuloplasty. There's a significant drop in trimitral gradient, but the LA compliance still remains, and the relationship to pressure half time is not in the same direction and not captured with the Hatley formula, and so therefore it can become inaccurate. And so in the 24 to 48 hours after balloon valvuloplasty using pressure half time would not provide an accurate estimation of mitral valve area. So for the purpose of time, I thought I'd move on, but I come back to this case if we're interested. But this is a case from the lab here. So I'll talk about some interesting low flow, low gradient mitral stenosis, and this is something that I read about, and these are in older patients. Because of the effect of LA and LV compliance, we can actually find reduced transmitral gradient despite having significant mitral stenosis. And this is, again, with reduced LA compliance, there can be a very high LAV wave with the rapid Y descent, so the atrium empties very quickly. But this high V wave can transmit pressure back to the pulmonary system and cause significant dyspnea and exertional intolerance. The same thing with reduced LV compliance. There's a rapid rise in diastolic pressure, all of which then creates a reduced transmitral gradient. And furthermore, with significant mitral stenosis, these patients have decreased LV stroke volume and decreased flow through that mitral valve, and therefore create lower gradients. But they're more common in older patients, which is the patients that we would tend to see because of the comorbidities related to hypertension, CAD, atrial fibrosis from obesity, age, and that can change compliance significantly. And on echo, we might be alerted to someone with tall mitral E waves, as I mentioned, related to this rapid emptying because of the low LA compliance. E wave EA ratio greater than 1 or a short pressure half time for the same reason as above. And these patients with these reduced LA and LV compliance have pretty poor prognosis and have a higher rates of cardiac events, but they're less responsive to valvuloplasty from a symptom perspective, despite successful valvuloplasty. Because of these all V waves and this reduced LA compliance, they can still have persistent shortness of breath. And so that's something to keep in mind. The role of stress echo tends to be used for where symptoms in the mitral valve area don't match. And this can be either exercise or debutamy, with exercise being preferred. And a hemodynamically significant rheumatic mitral stenosis will be an increase in mean gradient greater than 15 millimeters during exercise. And this is taken from the valvular guidelines. So in terms of managing rheumatic mitral stenosis, there's medical therapy and interventional therapy. Medical therapy would include anticoagulation if there's an indication, such as atrial fibrillation, embolic event, or an LA thrombus, and heart rate control, as I discussed all the hemodynamic factors of why heart rate can increase the mitral valve gradient. And then interventional therapies like balloon mitral valvuloplasty and surgical commissurotomy. I won't go into this figure in detail, but basically these are the 2020 valvular heart guidelines for indications and of which type of therapy for patients with rheumatic mitral stenosis. So echo plays also a very significant role in determining suitability for balloon valvuloplasty. Echo assesses the anatomic suitability for splitting of the medial and the lateral commissures, and how successful this would be to achieve the idea will be a valve area of greater than 1.5. And in addition to this, it looks at the risk of inappropriate increase in mitral regurgitation, which is the unwanted side effect of valvuloplasty. So because more calcified commissures can actually redistribute force in a different way. So it's very difficult to split calcium, but because if there's other areas other areas of the valve which are more pliable, that force that's generated from the valvuloplasty can actually tear leaflet cords, leaflets which are more pliable. So that increases risk of rupture. Similarly, asymmetry in calcium, commissural calcification, could also increase the risk of mitral regurgitation because you may deliver more force towards one commissure than another. And so those are some things that can be assessed on echo. TEE can assess for the severity of mitral regurgitation, and basically more than mild mitral regurgitation would have a suboptimal outcome for valvuloplasty, and then ruling out thrombus. So there's multiple scoring systems and one of the ones very well or commonly is the Wilkins score, which developed over 30 years ago. And then I'll briefly go over the Noon score. And finally, there's other scores that look at commissural calcification and using multiple factors such as NYHA class, valve area, mitral regurgitation, age, and sex. So the Wilkins score basically scores the morphology on mobility of the valves, subvalvular thickening, leaflet thickening, calcification, and grades them from 1 to 4, with the higher scores indicating less favorable outcomes. A total score of less than or equal to 8 would predict a favorable outcome. There are some limitations to know about this. As you can see, this is predominantly semi-quantitative, in fact, mostly sort of qualitative and subject to the observer. And so there can be significant inter-observer variability. Furthermore, they place an equal weighting on all of these factors, and they don't always have a similar predictive value for success of valvuloplasty. And finally, this doesn't predict the risk of mitral regurgitation. So in 2014, this Noon score was developed, and this was basically four factors, and they are autonomous ratings, either given a point or 0 points. And these look at mitral valve area of less than or equal to 1 centimeter, maximum leaflet displacement, which is basically the doming height, as you can see on this upper right image here, the distance from the annulus to the tallest part of the dome. And then commisural area ratio, which looks at the commissural calcification asymmetry that I talked about, which would be a predictor of mitral regurgitation, and subvalvular involvement. And the higher the score you place on this, the higher risk for suboptimal outcomes. So now I'm just going to talk a bit about pregnancy and rheumatic heart disease because it applies to this case, and I think it's interesting as we talk about rheumatic mitral stenosis. So this is a figure on the right side, as you can see, of the normal physiologic changes of pregnancy. And as the gestational age increases on the x-axis, there's an increase of all of these factors of heart rate, stroke volume, and cardiac output, up to 50% of cardiac output, and the highest is in the third trimester. In addition to this, there's blood volume, there's increased fetal mass, and there can be a decreased systolic blood pressure and decreased systemic resistance. So rheumatic mitral stenosis is, in fact, the most common valve lesion that we see in women of childbearing age. And you can see that why during pregnancy, all of the factors that I talked about can increase mitral gradient and the LA pressure. Both the heart rate increases, cardiac output, and plasma volume all decrease diastolic filling time and increase the flow through this narrowed valve. And during delivery, this is exacerbated by the sympathetic surge related to pain, anxiety, and there can be increased venous return from a contracting uterus because there's auto-transfusion of basically blood from this uterus to the intravascular space, and there can be relief of IVC compression as the baby's delivered, which then increases venous return and increases flow through this tight orifice. Maternal complications as a result of where the peak of these physiologic changes happen tends to present more in the third trimester. And so maternal fetal outcomes are quite significant for patients with mitral stenosis. As you can see in this figurine, this is from a systematic review and meta-analysis. There is a 3% risk of maternal mortality in severe mitral stenosis and 1% in moderate, and this is compared to 0.015% of maternal mortality in the general population. There's almost 40% rate of pulmonary edema in severe, as well as significant rates of arrhythmias. And fetal outcomes, fetal complications occur as a result of reduced placental blood flow, and so there can be stillbirth, neonatal death, or preterm birth. This is a registry of pregnancy and cardiac diseases that looked at rheumatic mitral valve disease in predominantly emerging economies. Interestingly, a lot of these patients actually had known mitral valve disease prior to pregnancy, and 27% have some form of repair that happened. But the figures are pretty significant. There's 1.9% maternal mortality. There's significant heart failure as well, and about 6% of them had intervention, majority with a valvuloplasty during pregnancy, and most of them had fairly uneventful pregnancy. And in the NYJ class 1 or greater than 1 was an independent predictor of maternal cardiac events. This is an echo. This was actually done out of the UHN group, but this is a look at echo assessment in pregnancy at baseline in the third trimester. And as expected, these are 56 patients who had echo that performed with known mitral stenosis. As expected, the mean gradient rises, RP rises, and so does the heart rate rise. And what I wanted to say here is that in these patients, they also looked at cardiac events, and having mean gradients of greater than 10 had a significant association with cardiac events, and the same thing with right ventricular systolic pressure of greater than 40 or 50. And when we relook at them in the third trimester to look at the echoes, having a gradient that surpasses the 10 millimeter mercury mark also increases cardiac events, and the same with an RVSP of greater than 40. So this will inform our way of assessing and monitoring these patients over the course of their pregnancy. And then in terms of the management, this has to be a multidisciplinary management involving multiple specialties. Pre-pregnancy counseling is very important. Severe mitral stenosis makes the risk of pregnancy prohibitive, and they really should be counseled on having intervention or having a low threshold for intervention regardless of symptoms. And medical therapy is predominant therapy that's used with beta blocker, diuretics, and anticoagulation if needed for these patients. And the attempt is to try to get them to continue with medical therapy as long as possible, and only in those who are refractory or because of persistent NYHA class symptoms would then get a balloon mitral valvuloplasty. The ideal timing is 20 weeks gestational age, and there's only case series and reports of this, but there is fairly safe and effective of balloon valvuloplasty. There obviously can be worsening mitral regurgitation, AFib, embolic events, cardiac tamponade. And mitral valve surgery really is for very, very rare cases because there's a 20 to 30% fetal mortality while on cardiopulmonary bypass. In mild disease with low NYHA symptoms and no significant pulmonary hypertension, these patients can deliver vaginally, but if more significant disease, they will tend to deliver by C-section. So I want to return to this case to show you some of the images from what happened. So she was diagnosed, as we saw from the initial echo images, with severe rheumatic mitral stenosis, and at the very same time, and she actually was not known to be pregnant before presenting, and she was found to be incidentally pregnant. She was seen by an obstetric cardiologist. She was initiated on Lasix and bisoprolol, and because of her high risk of decompensation related to her high mean gradient, as you recall, it was 23 millimeters mercury, decision was made to proceed with balloon valvuloplasty. And so some of the echo findings is that her mitral valve area by pressure half-time was at 0.6, and her Wilkins score was labeled as 8, so just on the borderline. This is intraprocedural TEE images that I thought was interesting to see. So you can see the morphology of the valves, the rheumatic appearance. There's clear diastolic flow acceleration with still mild mitral regurgitation. And then the gradient here was about 14 when they did this intraprocedurally. And just to note, the procedure itself included special considerations, including abdominal shielding, anesthesia, and she was under general anesthesia, and the involvement of obstetrics and cardiac surgery provided something unfortunately not the ideal option. And I thought this was a very interesting intraprocedural TEE, but we can basically see the balloon here being inflated across the mitral valve. And if it plays a little bit faster, I hope you guys can see that okay. It's a little bit slow on my end, but what we see is that it's opening and inflating, but there's this swirling of spontaneous echo contrast that I thought was actually really interesting looking at this in real time in TEE. But that's along with the balloon opening, I think the LA contrast is actually really interesting. Okay, and ultimately she had a pretty good result with her gradient coming down to 5, and she had persistent mild mitral regurgitation, as you can see, color Doppler. So her gradient decreased from 11 to 6 by invasive measurements and from 15 to 5 by TEE. By mitral valve planimetry, this was by planimetry, the mitral valve area is 1.3 centimeters. Because of increased spontaneous echo contrast, she was initiated on anticoagulation, and her the rest of her medication was stopped. She was ultimately discharged home post-procedure day 1, and hopefully she will be able to carry on the rest of her pregnancy safely and successfully. So that's the end of my presentation. I'm sorry for going over time and starting late. Apologize for that, but if you also want to take any questions or any discussion points.
So thank you, Flora, for giving such a comprehensive review. Just want to recognize Dr. Bob Chisholm, who is one of our colleagues at St. Mike's, who's actually pioneered the percutaneous mitral valvuloplasty, and definitely has taught a lot of the other cardiologists in the province about this technique as well. And when I first arrived from Montreal to Toronto, I thought we have an epidemic of rheumatic heart disease on Tuesday afternoon, because that's when Dr. Chisholm has his follow-up clinic when I first arrived. So just want to say thank you for your very comprehensive review. We'll answer the questions offline because of the time, and we'll let our colleagues going back to work.